Namaste, Dr. Asha.
Namaste,
And
Mr. Kawal.
everybody else also. And everybody else also.
Good evening, everybody.
And we are live now. So good evening all the delegates and faculties for the Core Connect live webinar, Searchlight 17 series, which is on the updates on primary dysmenorrhea. And this webinar is initiated by Cancer Prevention and Relief Society in association with Bhimavaram, Hapur, Haridwar, Himmatnagar, Hingoli, Hisar, Imphal, Islampur, and Jalandhar Obs and Gynae Society. So first of all, it's my privilege to welcome our convener, Dr. Sujayashree Sangeeta. Madam is a consultant ops and laparoscopic surgeon at Seshadri Hospital and also founder secretary of Bhimavaram Ops and Gynae Society, Imphal, and also secretary of IMA Palalkot. So I welcome Sujayashree ma'am and request you to please take it forward.
Thank you for those kind words of introduction, Mr. Mehul. It gives me great pleasure to introduce Dr. Asha Jain ma'am, who's the program director. Asha Jain ma'am currently is the director of SMSA Hospital Raipur. She's also the medical director of CPRS. She's the elected member of Chhattisgarh Medical Council, zonal chair, Foxy Food, Drug and Medicine Committee. She's the chairperson of Mission Pink Health IMA Raipur, executive member of ISCCP and Chhattisgarh ISAR chapter and also Chhattisgarh SFM chapter. The previous positions held by her was the president of Raipur OB-GYN Society, VP of IMA Chhattisgarh, president Rotary Club of Raipur North. She's received IOTA certification. She's also received training in colposcopy from AV School of Colposcopy. She's also the Indian School of Colposcopy and Cervical Pathology Colposcopy trainer. So it gives me great pleasure, ma'am, to invite you and request you to please take over, ma'am.
Thank you so much, Dr. Sujayashree. So we would start the program officially by seeking blessings from the divine.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा। असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय। ॐ शान्ति शान्ति शान्तिः।
Welcome, respected delegates, to this 17th episode of Searchlight series of webinars. The topic is updates in primary dysmenorrhea. We always try to keep everyday topics of interest. So this is in association with Bhimavaram, Hapur, Haridwar, Himmatnagar, Hingoli, Hisar, Imphal, Islampur and Jalandhar societies. I would like to welcome Dr. Mala Arora ma'am, Dr. Varsha Baste ma'am, Dr. Niranjan Chavan sir, and the convener, Dr. Sujayashree. I would also like to welcome Dr. Ragini Agrawal ma'am, the past VP Foxy, who has consented to be speaker, and Dr. Deepshikha Goel ma'am, Dr. Sujata Pradhan, and Dr. Sandeep Patel as chairpersons. Our second speaker, Dr. Taru Gupta ma'am, who has responded on a single phone call. She is HOD of ESI Medical College, Faridabad, and I've heard she's a great speaker. So welcome, Taru ma'am, and the chairpersons, Dr. Subodha, Dr. Gurneesh Singh, and Dr. Surjit Kaur ma'am. I also welcome our experts, Dr. Ruchi Bhargav ma'am from Jalandhar, Dr. Helen Kemei from Imphal, and Dr. Sarfaraz Kazi from Himmat Nagar Obstetric Gynec Society. Welcome also to my expert panelists, Dr. Uma Sharma ma'am, who's the president of Hapur Society, Dr. Namita Agrawal, Secretary Hapur Society, Dr. Sangeeta Singhal, President of Haridwar, Dr. Vishang Patel, Secretary, Himmat Nagar, Dr. Sonali Damkondwar, who's the President of Hingoli, Dr. Vidya Rani Bangar, Secretary Hingoli, Dr. Kumandam Devi, who's the Secretary of Imphal, Dr. Mansi Mandale, Treasurer of Islampur, and Dr. Sukriti Sharma, who's the Secretary of Jalandhar Society. I hope maximum would be able to join us. Welcome everyone. And Dr. Mala Arora ma'am just gave me a call that she is down with a severe flu and she's unable to speak. So we would just take her CV. She said, I give you my blessings, but I'm unable to speak. So I would just read out her CV before we proceed to our guests of honor. Ma'am Mala Arora is the past chairperson of ICOG. She was Vice President Foxy 2011, Editor Yearbook 2018, 19 and 20, Co-Chairperson WCRPL 2023. We all know of her great work on recurrent pregnancy loss. Years back, 2003 onwards, she's the Chief Editor of World Clinics in Obstetric Gynecology, Volume 1 to 10. She has the DC Datta Award for Yearbook of Obstetrics and Gynae, 18, 19, and 20, Chief Editor for First Trimester of Pregnancy and Hyperhomocystinemia. She's also the Associate Editor, International Journal of Infertility and Fetal Medicine, Peer Reviewer, British Journal of Obstetric Gynecology, and Journal of Human Reproductive Sciences. A very, very accomplished person. She would have been here but for her viral. So welcome, ma'am. We take your blessings with us as we go forward in this webinar. Now, I would like to introduce Varsha Baste, ma'am.
Namaste.
Namaste, ma'am. Thank you
Yes.
so much for accepting to be with us today.
My
We
pleasure.
all know she is the VP-elect Foxy, and she's a practicing gynecologist and infertility specialist in Nashik since the last 30 years, Director of Baste Maternity Hospital and Pushpa Fertility Center. She has credit for the first ICSI PGD baby in North Maharashtra way back in 2003. Past President, Nashik Society 2014, Chairperson Foxy IAEC 2019 to 22. She has the prestigious Dr. Anandibai Joshi Awardee, Amox V for Stree Puraskar by the Governor of Maharashtra, Champions of Foxy Award, Foxy Excellence Award. She's organized many conferences and we all know her for introducing Raj Yoga to all Foxians. So
Yes,
welcome, ma'am. We would like to have your blessings.
Thank you so much. Good evening, dear all. And I can see the gathering of massive faculties over here that tells work done by Dr. Asha Jain, such an active academician. And the topic also is the updates on primary dysmenorrhea. That is really basic and much needed for each and every gynecologist. And this webinar has chief guest Dr. Mala Arora, but unfortunately she's not there, but she is such an exemplary person, having thorough knowledge and in depth of knowledge, and such a lovely my friend, and also Raj Yogini. Like I'm sharing, I'm another guest of honor is Dr. Niranjan Chavan, who is also such an active Foxy leader. And I really wish him all the best for his further endeavors. Our convener is, I know her Suhasi, best wishes to her. She has done tremendous work that is seen on this brochure itself. My great friend, Dr. Ragini Agarwal, is a great orator and she will definitely give justice to this her topic of etiopathogenesis of primary dyspnea. Deepshika Goyal, I know all my friends are here. Sujata Pradhan, Sandeep Patel. Also, the next session is by Dr. Taru Gupta, and the panel discussion is by Dr. Asha Jain herself, and so many societies. And I can really, I'm wondering how many people you could gather, Dr. Asha Jain and all the organizing people in this webinar, Bhimavaram, Hapur, Haridwar, Himmatnagar, Hingoli, Hisar, Impal, इस्लामपुर जालंधर वो तो इंडिया ही कलेक्ट कर लिया आपने but I'm really happy to be here and really I'm happy you are doing wonderful webinar, Dr. Asha, and I wish you all the best for your further election, and you are really a great person having great academic credentials. I wish you all the best and thank you for having me here. I'm honored to be a guest of honor. Over to you, Dr. Asha Jain. Thank you so much.
Thank you so much, ma'am, for all those kind words. Thank you so much. It's actually fun to get the whole thing together. And when we have East, West, North, South, the amalgamation we have is really all of India.
Yes.
So, may we have Niranjan sir CV, please? So everybody knows Dr. Niranjan Chavan sir. He is professor and unit chief, LTMMC and LTMG at Sion Hospital, president of MOGS 2022 to 23. He is the elected joint treasurer of FOXY till 2025, organizing secretary ICOG Mumbai 2025, treasurer AFG, member Oncology Committee CEFOC, Dean EGOG, and Chief Content Director, Hygrad and FAMAS courses, Editor-in-Chief FAMAS, JGOG, and TOA Journal, has 77 publications in international and national journals with 189 citations. He's also the National Coordinator for FOXY Medical Disorders and Pregnancy Committee, Chair, Convener, FOXY Cell Violence Against Doctors 2015 to 16, Member Onco Committee AOFOC 2013 to 15, Coordinator of 11 batches of MUHS recognized certificate course of BIMIE at LTMGH, Member Managing Committee IAG 2018 to 20, 22 to 23, Editorial Board European Journal of Gynec Oncology, course coordinator of 3 batches of advanced minimal access gynec surgery. More than that, we all know him for his work in gynec oncology and for the work for masses at Sion Hospital. That is where I heard about him and I was really impressed. Welcome, Niranjan sir. We would love to have your comments on this webinar. Sir, you're muted. Niranjan sir, you're muted. So you're still muted. Yeah.
Thank you so much, Dr. Asha Jain. It's a pleasure to be there with you today on the program of Searchlight 17 updates on primary dysmenorrhea in association of so many societies. We have already named them, so I don't want to be a barrier between the delegates and this program. Thank you, Dr. Varsha Basti. You have been a kind human being. And as you said, as a Raj Yogini, I remember those days in COVID times. You have done wonderful work. Now, as a vice president,
Thank you so much.
it's great to see you on the same platform as me. Dr. Mala Arora is not there, but her blessings are there always. And I find that the speaker is none other than the vibrant Haryanvi, Dr. Ragini Agarwal.
Yes.
And she is our colleague, and she is going to speak on etiopathogenesis of primary dysmenorrhea. Of course, we have the convener, Dr. Sujaya Sri Sangeeta. Thank you so much for inviting me today. And then we have speakers like Dr. Taru Gupta and Dr. Asha Jain herself moderating different situations of primary dysmenorrhea. And it's a total win-win situation where you have discussed, where you're going to discuss the next 2 hours, the whole gamut of primary dysmenorrhea and the causes, the effects, the etiology, the pathogenesis, the management. And I'm sure the delegates are going to go back home with a lot of knowledge, which they will utilize that in their day-to-day practice. So I'm really very, very happy to be a part of this as a guest of honor. And I wish Dr. Asha Jain all the best for her future endeavors. And I'm sure she'll come out with flying colors. I don't want to name so many of members who are succeeding, but I really appreciate their efforts and the dedication that they are taking out the time to be with all of us. And this will be a recorded video YouTube. I'm sure it will be beneficial for all the members later on also. So thank you so much. All the best and see you all soon in AICOG Mumbai.
Thank you,
We
sir.
all welcome you.
Thank you.
We all welcome you. We are expecting 13 to
Yes.
14,000 gynecologists from all over the world. And please do come and enjoy
right.
scientific fiesta.
Thank you, sir. Thank you so much.
Thank you.
So with this, we have completed our inauguration. I thank the dignitaries, Varsha ma'am and Niranjan sir for gracing the occasion. Now, I would like to request all the viewers who are on YouTube, you can like and subscribe. You can also type in your questions, which we will be taking after the session. So you can type in your questions and we will take them at the end of the session. Over to you, Sujay.
Thank you, ma'am. So we proceed to the next segment. Session 1 is etiopathogenesis of primary dysmenorrhea. So I would like to introduce the chairpersons of the session. Firstly, we have Dr. Deepshika Goyal. Ma'am has completed her graduation and post-graduation from MLN Medical College, Prayagraj. She's a consultant at Nidhan Nursing Home. She's been working since the last 31 years in Hapur. She's currently the secretary of Hapur Obstetric and Gynecology Society. She's also a member of Hapur Menopausal Society. Welcome, ma'am, to today's session. Next, we have Dr. Sujata Pradhan Sehgal. Ma'am is a consultant gynecologist at Ayurveda Clinic, Haridwar. She's currently the secretary of Haridwar Obstetrics and Gynecology Society. She has been the past treasurer of the same. She has served as a medical officer in Indian Army, has been an ex-SR at Army Hospital, Delhi Cantonment. Welcome, ma'am. Lastly, we have Dr. Sandeep Patel, who is currently the president of Himatnagar OB-GYN Society. He has an experience of 15 years. He has his private practice in Idar, Gujarat. He has been the past president of the same society. He has also been a past president of Idar IMA branch. He has been an organizing vice chairperson at SOCOG, special interest in laparoscopy and fetal medicine. Welcome, sir, to today's session. I request one of the chairpersons to please introduce the speaker, Dr. Ragini Agarwal. Dr. Deepshika Goyal, would you like to? Yeah, ma'am.
Yeah, bilkul. Good evening, everybody. And I am very thankful to Dr. Asha Jain for giving me this opportunity to join you all. And Dr. Ragini is founder and president, Indian Society for Aesthetic and Regenerative Gynecology. She is founder and president, Indian Academy of Cosmetic Dermatology and Gynecology. She is founder, president-elect, North India Gynae Forum, NIGF 2022. She is founder, chapter convener. She is general secretary-elect, IMS 2425. She is vice president, FOXY 2020. And she is founder, committee chairperson, Aesthetic Health, Indian Menopausal Society. She is founder, president, Association of Obs and Gynecologists, Haryana. National Chairperson, Public Awareness Committee. She is founder, secretary, IMS Gurgaon chapter. She is national convener, Indian Menopausal Society. She is patron Gurgaon Menopausal Society. She is chairperson
Thank you
Public
so
Health.
much.
Okay,
Thank
thank you,
you.
ma'am. Please.
Webinar itself.
Ji.
Thank you so much, Dr. Varsha, for kind introduction. And thank you so much, Asha ji, for giving me this opportunity. But the problem is that I don't have my slides with me. Please bear with me because my brother has some problem. I have to go to my native place. I will speak like this. It will be do
Yes, ma'am, sure.
without slides.
Why not?
Yes, ma'am.
So, dear friends, when we talk about the primary amenorrhea,
Ma'am,
we are
dysmenorrhea. Dysmenorrhea. Dysmenorrhea.
primary dysmenorrhea.
Yes,
Okay.
ma'am.
But I have
Ma'am,
prepared
okay.
primary amenorrhea. Okay, no problem. So usually the patient which comes to us with the primary dysmenorrhea, first we have to keep in our mind this dysmenorrhea when the patient come to us of any age and have so many problems. The first problem who came to me, the first patient who came to me, she was a 12-year girl, and I got a phone call from my pediatrician that, look, madam, my patient is having an excruciating pain, is not responding to any treatment. I am sending to you. Friends, what can be the diagnosis when a patient is come to you at this age? The first diagnosis always in our mind is something like Mullerian agenesis. Yes, that patient is an imperforate hymen. I took that patient to the OT, give a neck, and blood came out and patient is relieved immediately. The gratification on the face of the parents are immense. So primary dysmenorrhea coming to us, always these are the women who are having some or other, many a time a structural problem like absent vagina but present uterus, and the most important thing is the imperforate hymen which we come across. The second example of the Mullerian agenesis I will give you. This patient came to me as a very strong pain and not able to even properly consummate the marriage. And at that time, that woman has a severe pain. When I try to do a per vaginal examination, she almost kicked me. So when I talked to her, every menses, it was unbearable, and this pain is gradually increasing. So what it can be? Because this patient is menstruating also and too much of the pain. And this patient, when we go in the depth to diagnosis, this patient is a case of Ochvira syndrome. There's a hemivagina and there's a two uterus, there's a complete septate uterus. Many a time this Ochvira syndrome, they have a didelphus uterus and she has a renal agenesis also. Here, again you have to resort to a surgery, cut the septum, relieve the passage, and the whole menstruation will come out and patient is relieved. So today with the ultrasound, things have become very easy. This patient needs a proper whole diagnosis and imaging, and you have reached to a conclusion. And third scenario which I can give you for the primary dysmenorrhea is a patient who is young girl having a menstruation, coming to you with a severe abdominal pain during every cycle. Please don't think that this patient is not having anything. And not just give up. These are the girls who needs again to think of a primary endometriosis, and which is going to cause a problem to her in the future. Many a time we neglect these girls, and this endometriosis will go increase in size and can affect her future infertility. So these are the three scenarios which I have told you that we should always keep in mind. Next case of the primary dysmenorrhea is a which I handled is again a young girl at the age of 14, and she has a torsion of the ovary cyst. This was not, I can't say that this time, the first time she has a pain, but she was having a late cycle, and first time she has a first menarche at the age of 13 years. And every time she has little bit pain, but this 10th cycle, she has a excruciating pain. Then she came to us and we found a 6 centimeter ovarian cyst, and that patient was again operated. And when we operated, we found this simple cyst has a chocolatey fluid. So what I am trying to give you a practical scenario, not the theory which we all can read on the internet today, because every theory is there on the internet. Any patient coming to us with a primary dysmenorrhea is usually a young patient, and these young patients, we have to investigate in detail those young girls with the imaging and accordingly act. Last scenario which I can talk, no doubt a primary dysmenorrhea which has no structural problem, no pathological problem, and usually those initial primary dysmenorrhea is a congestion syndrome. It is always there first or second day, and gradually this pain decreases. Pain decreases by the second and third day. These are the girls who needs a counseling assurance from you and some type of the treatment, specifically the painkiller you can give. Today, we all know there's a black box warning and a question mark on the Meftalispas, although we are giving day in and day out for years this Meftalispas. So always I talk about a medico-legal point. When you give a Meftalispas in the today's world, you must tell them that this drug is somehow a question mark related to other problems also. So I think I'm so sorry not having those slides with me, which I made for you all. But this is the primary dysmenorrhea, how I can see a primary dysmenorrhea from a clinician point of view and with a practical point of view, not a totally a bookish primary dysmenorrhea, which I have to talk. Ashajit, I think they're calling me inside the hospital. Okay.
Thank you, Ragini ma'am. Thank you for whatever
Thank
you
you
have
so
been
much.
able to say. And
Yeah.
I would request the chairpersons to say a few words and stay on for the second lecture as well. Ragini
Thank
ma'am,
you
don't
so much.
worry. You please go ahead with your brother to the hospital.
Thank
We will take the program forward. Don't feel bad
Thank
because in an emergency, nobody can remember all this.
Yeah.
I'm very
Thank you
thankful
so much.
that you at least came around. Thank you so
Thank you
much.
so much. Thank you. Thank you.
So we'll go ahead with the next session. Yeah, so moving forward to the next session, which is management options of primary dysmenorrhea. I would firstly like to introduce the chairpersons of the session. We have Dr. Subodho with us. He's currently the president of Impal OB-GYN Society. He's the chief consultant and endoscopic surgeon in the Department of OB-GYN in Shija Hospitals and Research Institute, Impal. Welcome to today's session, sir. Next, we have Dr. Gurneesh Singh. Dr. Lieutenant Colonel Gurneesh Singh. He's a former professor and HOD in Maharaja Agar Sen Medical College, Akroha. He's currently the president of Hisar OB-GYN Society. He has a lot of papers to his credit. He has worked as a consultant and professor at Army Medical Corps, MAMC Agroha, the Medical College, and Ellora Eve Care Hospital and IVF Center. He has many honors to his credit, especially he's received the Chief of Army Staff Commendation in August 2004. So he has teaching experience of more than 16 years. It's an honor to have you with us, sir. Welcome to today's session. Lastly, we have Dr. Sujit Kaur. She is the president of Jalandhar OB-GYN Society, vice president Hisar Punjab chapter. She has also been the past secretary of Jalandhar Menopause Society. Welcome to today's session, ma'am. I request Dr. Subodh to please introduce the speaker, Dr. Taru Gupta, ma'am.
Good evening, everyone. After hearing the introductory remarks about primary dysmenorrhea, now we move on to the next topic, this management options of primary dysmenorrhea. And our speaker will be Dr. Taru Gupta. But before I introduce Dr. Taru Gupta, I would like to give my thanks to Madam Dr. Asha Jain, the Program Director, for giving me this opportunity to chair the session. Professor Dr. Taru Gupta is Head of Department and Professor Obs and Gynae, ESI Medical College, Faridabad. She is also Chairperson of Public Awareness Committee, GCF, and Executive Member, AOGD and DGF Southwest. She is also member of Delhi Society of Gynae Endoscopists and also NARCI, Delhi. Dr. Taru Gupta has had many awards, including Dr. APJ Abdul Kalam Appreciation Award 2023. She has had the Best Paper Award in Senior category in Jogi Foxy 2020. She is also trainer of Emergency Obstetrics Care. And she has had many publications in index journals, and her areas of interest are high-risk pregnancy, advanced endoscopic surgery, and gynecological oncology. So I invite Dr. Taru Gupta to speak on the topic management options of primary dysmenorrhea. Dr. Taru Gupta, please.
Thank you, sir. Thank you for the kind words. At the outset, I would like to thank Dr. Asha Jain, the program coordinator of today's academic forum, for giving me an opportunity to be the part of this program. Can I share the screen, please?
Yes, ma'am, please do. Mr. Mehul,
Is it visible? My slides are visible?
yes, ma'am, you can make it full screen, ma'am. The slides are visible. Yeah, now it's perfect, ma'am.
At the outset, I would like to thank Dr. Asha Jain, madam, for giving me an opportunity to be part of this great webinar on a very wonderful and a very common topic, which is very ignored. Commonly, it is ignored. It is underreported, underrepresented, undertreated. And I also thank Dr. Ragini Agarwal to give me an opportunity to this program. So, dysmenorrhea, primary dysmenorrhea and secondary dysmenorrhea. My talk will cover the definition, types, pathophysiology, epidemiology, and management. So dysmenorrhea is defined as...
Would you just hold on? Requesting chairpersons of the first talk also to be on this, because ma'am will be taking both the things together. So thank you so much.
Thank you, madam. So dysmenorrhea is classically described as pain at the time of menstruation. It is crampy in nature and it is located in lower abdominal region. There are two types of dysmenorrhea, we all are aware, primary and secondary. Primary, when there is a pain without any identifiable cause. That is, there is no pathology, pain during the ovulatory cycle, and the cause is myometrial contraction and release of prostaglandins, primarily PGF2 alpha and PGE2. The secondary dysmenorrhea is when the pain is associated with pelvic pathology. It is commonly seen in patients with endometriosis, adenomyosis, PID, fibroids, interstitial cystitis. So along with pain, lower abdomen, the patient complains of nausea, vomiting, fatigue, bloating. There could be constipation, there could be diarrhea, breast tenderness. Then the patient may complain of headache in few susceptible individuals. There could be mood disorders like anxiety, depression, irritability, and mood swings. So all these things are reported by patients. So coming to case one, a 16-year-old adolescent with complaints of severe lower abdominal cramp every month, 2 to 3 days prior to the onset of menstruation, gradually decreasing after the onset of bleeding, intermittent in nature, and associated with fatigue and nausea. So this is a typical picture of primary dysmenorrhea. So symptoms as described for primary dysmenorrhea are the menstrual pain, which begin within few months or within 2 years of menarche. So the younger age group will have primary dysmenorrhea. As the age advances, the frequency of primary dysmenorrhea decreases. Pain starts right before menstruation or at the onset of menstruation. It is located in the lower abdominal, can radiate to back, inner thigh, or both. Pain seldom lasts more than 72 hours. It is episodic and crampy in nature. It is similar from one menstrual cycle to the next, and there could be additional symptoms. On the other side is case 2, which is 35-year-old lady, para 2, life 2, with complaints of abdominal pain, gradually progressive, starting 8 to 10 days prior to menstruation and increasing with time. It may last throughout the cycle. It can be associated with pain during coitus or with painful defecation. So there is a pelvic pathology which is responsible for secondary dysmenorrhea. Now coming to the pathophysiology, it is basically once the patient ovulates, there is presence of progesterone, and if there is no conception, so the corpus luteum disintegrates, the progesterone decreases, and it leads to shedding of endometrial lining during the menstruation. So it results in release of prostaglandin F2 alpha and E2, which causes increased myometrial contraction, which leads to vasoconstriction and uterine ischemia. So the uterine ischemia, it results in production of anaerobic metabolites, which stimulate the pain receptors and causes pelvic pain. The prostaglandins also cause hypersensitization of the nerve fibers to pain. So this is what I said, that progesterone fall causes endometrial sloughing, leading to release of lysosomal enzymes. And this lysosomal enzymes, they degrade the cell membranes with the which releases arachidonic acid, which is the precursor of prostaglandins. Like in this slide, you can see there's a release of activation of phospholipase A2, which causes release of arachidonic acid, and which finally leads into conversion of different types of prostaglandins. And the pain is primarily because of PGF2 alpha and PGE2. In this slide also, we can see that the similar thing, what I said, and it is the leukotrienes and prostaglandins interplay, which results in ischemia and pain, and it affects the quality of life of women. So it affects the sleep, it affects mental status, it affects the quality of life, and leads to chronic pain syndrome. Therefore, it should not be neglected. So that it results for absenteeism from school in 14 to 51% of children, young girls, adolescent population. So it affects the quality of life, and WHO defines quality of life as individuals' perception of their position in life in context of the cultural and value system in which they live and in relation to their goal, expectations, standards, and concerns. So 45 to 95% of female during childbearing age are affected by primary dysmenorrhea. 2 to 29% experience severe pain. 70 to 90% are less than 20 years old, 24 years. And we also heard that there is always a debate regarding the period leave or menstrual leave, which has got the attention of many people. So in many countries, in fact, they are working towards this. And Spain is one of the countries where they give menstrual leave or period leave for 3 days in a month to each. It may be paid, it may be unpaid, but leaves are given legally to the female woman population. Now with this brief etiology, I am coming to the management of primary dysmenorrhea. So primary dysmenorrhea, the aim is to provide dysmenoric female adequate pain relief that permits them to perform usual activities, improve their quality of life, and decrease their academic and work-related absenteeism. So both pharmacological and non-pharmacological, complementary and alternative therapies, they are the potential options for management. The first-line therapies recommended are non-steroidal anti-inflammatory drugs and hormonal contraceptives. Since they both inhibit the production of prostaglandins. We all are managing these patients, but still somehow we neglect these patients, and the patients too do not come for the management. They suffer. They take it as a thing that females have to suffer. This is a regular thing, and we have to suffer. We have to go through this phase each cycle. So for females with typical medical history and typical presentation of primary dysmenorrhea, we do not need any testing. It is preferred to initiate empiric therapy with either NSAIDs or hormonal contraceptives. There is no evidence favoring efficacy of either NSAID or hormonal contraceptive over the other. If treatment with one modality fails or proves to be inadequate after a period of 3 to 6 months, patients' adherence to the therapy must be assessed before switching to other modality. if the patient is symptomatic on one regime, then we can go ahead with combination of both the things, NSAIDs plus hormonal contraceptive. To optimize treatment efficacy and ensure patient satisfaction, it is always recommended that we need to do a shared decision making. A doctor-patient shared decision making is very important. We need to educate our women, our girls about dysmenorrhea, why, what is the cause, what are the treatment options, what are the adverse effects with the drugs, so that they can take the call. Because one of the modalities is hormonal contraceptives, so we have to take into consideration the patient choices, her preference, her desire for contraception, MEC criteria. So all these things to be considered. So all the major societies, ACOG, SOGC, American Society of Family Medicine, so all these, they recommend that extremely effective empiric therapy use either NSAIDs or hormonal contraceptives for 3 to 6 months. So NSAIDs, we all know that menstrual cramps and intensity of pain, they are correlated with high concentration of prostaglandin F2 alpha and E2 in the endometrium. So NSAIDs are considered as a cornerstone in the management of primary dysmenorrhea, as they inhibit the action of cyclooxygenase. They reduce prostaglandin synthesis. They do have direct analgesic activity, but definitely they have adverse effects like GI disturbances. So they can be given with meals or after meals, or a proton pump inhibitor may be added. If intolerant, we can give them acetaminophen, which is crocin, which is a mild analgesic. So this slide shows a list of drugs which are approved for use in dysmenorrhea, COX-1 and COX-2 inhibitors. So among them, what we generally use is mefenamic acid. So mefenamic acid, either as a meftalspaz, which has dicyclomine plus mefenamic acid, or Drotin M, which contains dotaverine with mefenamic acid, which we commonly advocate and we use in our practice. So the drugs flurbiprofen, it is also available in market. It is also given as a optimal drug for dysmenorrhea. So this is a drug with doses which is approved by FDA. Regarding NSAIDs, it is very important that the timing is very important to predict its efficacy. So for optimal treatment efficacy and safety, they should be initiated 1 to 2 days prior to the predicted onset of menses, administered with meals to decrease adverse event, and regular dosing regime should be given for first 2 to 3 days. Because once the cascade COX-2 cascade will start, then the effectivity will decrease. So before start of periods, it should be given. And once the cascade is started, then there will be a gradual or incomplete suppression of the cascade. So a scheduled dose regime is recommended. It should be started 1 to 2 days before the onset of menses, and a higher loading dose followed by low dose. That is, you saw in the slide that for mefenamic acid, the advocated is 500 milligram, then 250 milligram every 6 hours. Similarly, for all drugs, you can see initial there is a higher dose followed by a lower dose instead of traditional same dose regime. It should not be given like as needed basis, as we propagate of what we practice. जब भी pain हो तब ले लेना. So this is the practice which we follow, and this is what is evidence-based medicine says, that it should be a scheduled regime. Most optimal is flurbiprofen and tiaprofenic acid. And it is said that if the patient has side effects or with normal other NSAIDs, or she is having peptic ulcer disease or coagulation abnormalities, then a COX-2 inhibitor, which is expensive and not freely available, celecoxib, is said to be reserved for those women. Coming to hormonal contraceptives, they are also considered as first-line therapy for management of dysmenorrhea unless contraindicated. They are recommended for women who need contraception, for whom the contraceptives are acceptable, or who cannot tolerate or not responsive to NSAIDs. Hormones containing estrogen and progesterone are effective in managing dysmenorrhea. We all know that they will cause anovulation, and they will suppress endometrial proliferation. So they will decrease the prostaglandins, they will decrease progesterones, which are causative agent for dysmenorrhea. So among hormonal contraceptives, it is the combined OC pills which are most commonly utilized for this indication. And the relief of symptom is even seen with the low dose pills, that is, which contain 20 microgram of ethinyl estradiol. So COCs are effective in 70 to 80% of women. mechanism, as I already said, it decreases, it inhibits ovulation, decreases prostaglandins, progesterone, and vasopressin production. It can be given orally, intravaginal ring or patch. Extended use ossipils are more effective than the cyclic use, like seasonal. We know that we can give it continuously for 3 months. So it will decrease periods and it will cause an evolution, and there will be no periods, no decreased progesterone, prostaglandins. So the patient will be symptom free. Definitely there is a risk of DVT, but if the patient has a history of thromboembolism or there's a history of migraine with aura, we should not give combined hormonal contraceptives. In those patients, we can give progesterone only method. The etonogestrel implants available by Implanon, it is effective at 85%. Dempa, then progesterone only pills or LNG intrauterine system, they are also very effective. In fact, in patients who use Dempa regularly and LNG IUCs, they have 30% and 50% respectively amenorrhea at 1 year of use. So this is a list of hormonal contraceptives which is approved for treatment of primary dysmenorrhea. We can see it is combined ossipils, monophasic or multiphasic, extended cycle ossipils, then other hormonal contraceptives like Implanon or Nexplanon, then NuvaRing, which contains both estrogen and etonogestrel, then Mirena or Dempa injections. They all can be used for dysmenorrhea. They are approved for use in dysmenorrhea. Side effects, we are aware, and we have to counsel the patient regarding this to increase the adherence and compliance issue. Now, there are few drugs which are used off-labelly, nitric oxide donors, like they also, it is said that we know that nitric oxide causes smooth muscle relaxation and vasodilatation. So GTN patch, the glyceryl trinitrate patch, available 0.1 milligram, it is effective in 90%, but 25% of users, they complain of headache. So this is not, this slide shows the medicines which are not evidence-based, which are people they use off-labelly. So magnesium is also said to decrease menstrual fluid prostaglandin level, causes muscle relaxant and vasodilatation. Then calcium channel blocker nifedipine into 20 to 40 milligram doses. It decreases prostaglandin, but the side effects, transient flushing, tachycardia, and headache with higher dose. Vitamin E is also said to be helpful. In 200 milligram to 400 international units, it increases the production of prostanoid vasodilators, that is prostacyclins, and decreases prostaglandins. Therefore, it improves the oxygen delivery to myometrial cells. Then the other herbal things, ginger and herbal rose tea, sweet fennel, seed extract, fish oil, omega-3 fatty acids, their use has also been given in literature. Now coming to non-pharmacological interventions like yoga, meditation, then eating healthy food, green leafy vegetables, adopting healthy lifestyle, exercise, they play a very important role. They increase blood flow, they increase endorphin release, they lower stress and anxiety. So it is very important, and we have to tell our patients and girls to follow exercise schedule and adapting healthy diet. So for adolescent, they say that they have to at least practice 60 minutes each day, moderate or with vigorous intense aerobic physical activity, and adults should preferably do 2.5 hours per week of moderate intensity or 1.5 hours per week of vigorous intensity. A word about TENS, a transcutaneous electrical nerve stimulation. It is a non-invasive treatment modality proven effective in reducing menstrual pain. It needs a small battery-operated portable device which is applied to pelvic surface through electrodes which deliver electric currents. So high-frequency TENS, that is 5 to 50 hertz, it is used as the protocol, and it is helpful in 30% of women with severe dysmenorrhea, and it lowers the dose of NSAIDs to manage. So basically, it sends electrical impulses through the sensory fibers of the nerve root. So the threshold of reception of signal is elevated. So pain is not perceived. It also simultaneously releases endorphins, reduces pain, and it reduces uterine muscle hypoxia by increasing local vasodilatation. So these three mechanisms are described in literature. So basically for this, the patient does not need to be sedentary. वो अपने आप अपना TENS का लगा के pads, electrical pads, she can go to work, she can go to school. So this is a thing which can be given to young girls. It does not. It does not need that patient should be patient should be in bed or patient needs admission. Now about acupuncture and acupressure. So both these methods, they stimulate designated anatomical locations that relieve pain. So various points have been described. And acupuncture, it uses thin needles at these points. Acupressure uses firm massage. So basically the mechanism is that they alter pain modulation, increase in uterine blood flow, decrease prostaglandin. So the frequency described is that for acupuncture, once per menstrual cycle, to daily for 7 days, or acupressure 1 minute to twice daily, or up to 5 times per day. Now, topical heat, majorly practiced. So local heat, it increases the blood flow, it improves tissue oxygenation, and has a dilutional effect on intravascular prostaglandins. So nowadays, the heat wraps or patches are also available. So the patient is mobile. These patches are thin and they can be worn under the clothes. So it is inexpensive, easily accessible, and can be used in combination with other treatment modalities. So the algorithm is that the first number was we have to diagnose primary dysmenorrhea based on the symptom presentation. We need to offer them NSAIDs. For example, we can give ibuprofen 400 to 600 milligram every 6 hourly. And we can continue with this for 3 to 6 months. If the patient does not respond, then we can switch on to hormonal therapy. If the patient needs contraception, then the first drug would be hormonal therapy. And together with adjunctive therapy, reassess at 3 to 6 months. If there is a positive response, then we can continue. If the response is suboptimal, then we need to reevaluate. Now we have to examine the patient. We have to do investigations. We have to do imaging. And we have to know the secondary cause, because the cause for secondary dysmenorrhea is always a pelvic pathology. Surgical interventions, very, very rarely needed for primary dysmenorrhea, but described in literature like LUNA and the sacral neurectomy, the sacral nerve ablation. They basically involve the interruption of cervical sensory pain fibers through the transection of afferent type fibers, either in the uterosacral ligaments. Follow-up is very important, because we need to follow these patients closely, and they can be followed by visual analog scale or numeric rating scales. Both these scales are reliable, valid, and simple tool, and this should be assessed at the first visit and then after treatment also on subsequent visits. So key points is that for managing primary dysmenorrhea, it is a common disorder of reproductive age. It usually go underdiagnosed and untreated or inadequately treated. It negatively affects quality of life. Treatment is mainly based on pain relief. So in typical presentation, empirical therapy, and there is no one-size-fits-all algorithm. And generally, we give NSAIDs and hormonal contraception as first line. Patient declining for contraception, hormonal medicine is number one, which should be given, but we need to consider the MEC criteria. For patient not desiring contraception, definitely the NSAIDs are the first line choice. Additional treatment, they are used in concert to provide additive benefit. Now, to take home messages, dysmenorrhea severely impairs quality of life of adolescent and women in reproductive age group. Constant social debate is about the need to recognize the same and provide leave or sickness benefits. They are manageable with pharmacological, non-pharmacological, and surgical methods. Always keep patient informed and help them in making informed decisions on managing the same by providing feasible options. Explain the risk-benefit ratio of each modality of the management, and counsel regarding importance of healthy lifestyle as preventive method at early adolescence itself. So it is very important that they adopt a healthy lifestyle so that they can prevent many things in life. So with this, I conclude, and thank you so much. Thank you for the patient hearing.
Thank you so much, ma'am. Over to all chairpersons for your comments and if you want to ask any questions. All chairpersons may please interact.
First of all, I will like to thank Dr. Asha Jain for organizing such an important webinar on primary dysmenorrhea, which is a neglected topic, but very important. And I will also thank Dr. Daru Gupta for such a detailed presentation, almost covering up all the aspects. But certain aspects I wanted to highlight. Like in the risk factors for the primary dysmenorrhea, it is low BMI, high BMI, age less than 20 years, family history of dysmenorrhea in the family. So all these are multifactorial factors. So genetic factors and environmental factors both are important as far as its etiology is concerned. And second, I was saying that whenever we try to treat this dysmenorrhea along with the drugs, I think it is also important to give them psychological benefit. Sometimes just sitting along with the daughter also helps her a lot. Not only giving her one tablet of Brufen and all. That's all.
Thank you, sir.
Thank you, sir. The others could please, yeah.
Thank you, Dr. Asha, for providing this virtual platform to all of us. It was very informative and very good lecture by Dr. Taru. And she has given all the details of the primary dysmenorrhea. Especially in the young girls, it is really bothersome problem for the girls, missing the school and everything. So this problem should not be ignored. It should be timely cured and properly guided to the girls. If first of all, we can give them an aside, or that should be also be encourage them to take it 1 to 2 days before the start of the menses. So if it is not relieved, then OCPs and all other so much details we have come to know. Thank you, ma'am.
Thank you, ma'am. Thank you so much. Dr. Sujata, would you like to say something? Dr. Sujata Pradhan. Dr. Subodha, sir, would you like to add something?
Congratulations, Dr. Taru Gupta, for the beautiful discussion on the different management options. She has mentioned about many non-pharmacological management options of this primary dysmenorrhea. And from my practical experience, I would also like to emphasize on this importance of this psychological support, as Dr. Gurneet Singh has also rightly pointed out. Proper counseling and giving psychological support and telling them that it's not something to be dreaded about, is not a very pathological problem, and with good counseling and giving a support, psychological support, we can manage most of the cases which I have encountered. About the drugs and the other modes of therapy, she has so beautifully explained. So thank you once again. And if there are any other inputs, we can take it. Otherwise, we can conclude this session.
I think we have Dr. Deepshika Goyal with us. Ma'am, would you like to add something?
And just one point more, ma'am. Doing ultrasound will not be, totally out of the mind, because all these days children are always on the net. And whenever any girl comes to me with the dysmenorrhea, which I feel it is dysmenorrhea because of her history, she has already read so much about Google and everything, that sometimes it is much better that one ultrasound is done and told her that no abnormality has been found. It is only primary dysmenorrhea.
Yes, so definitely tender loving care is number one. We have to counsel, and the counseling is very, very important. If we counsel the patient properly, we give 15 minutes to the patient, it will dramatically affect. Secondly, in a metro cities where we are sitting, definitely we should advise, we can do a local per abdominal examination. We can go ahead with ultrasound also to rule out. But for primary dysmenorrhea per se, if there's a typical presentation, it does not need anything investigation to prescribe. So, but definitely when a metro station, we need to do imaging, because ultrasound is not an investigation. It is basically an examination tool only. So we can definitely exclude the causes of secondary dysmenorrhea.
Yes, we cannot overemphasize on the importance of counseling and reassurance.
Yes.
This will give a long way, in relieving their symptoms. Right. Thank you.
Thank you, sir. Thank you for the inputs.
Yeah, so we thank Dr. Taru Gupta, ma'am, for that wonderful talk. And I thank all the chairpersons for their active participation. So we'll move ahead to the final segment, which is the panel discussion. So we have Dr. Asha Jain, ma'am, who will be moderating the session.
Thank you so much, Dr. Sujya. My request to everyone present, you're all welcome to pitch in. We have our respected panelists, our experts, and everyone present. I have already been introduced, and thank you, Sujya, for that. I request all of you to please support my candidature for Food, Drug, and Medico-Surgical Equipment Committee, FOGSI. You will have the nominations in your hand in May. So nominations will be in May, and then the elections will be in August. Please do support. So I've already named everyone, and I'll take their CVs one by one. Our expert is Dr. Ruchi Bhargav, ma'am. She is from Jalandhar, Director of Bhargav. I met her in a webinar of Dr. MC Patel, sir, and she was, I just thought that I wanted her an expert. So welcome, Dr. Ruchi, ma'am.
Thank you very
We
much.
have Dr. Helen Kemei, who's an associate professor at JLN Institute of Medical Sciences, Imphal, a dear friend and very, very interested in women's well-being. Dr. Sarfaraz Kazi, sir, who's the director of Navjeevan Women's Hospital, Himmatnagar. He has an advanced training in gynec oncology, Ahmedabad, fellowship in reproductive medicine, diploma in endoscopy. He's a member of Society of Fetal Medicine, organizing vice chairperson Sogok 23, and president of Himmatnagar Society. Welcome, Dr. Kazi. President of Shang Patel, Secretary of Himmatnagar Society. Dr. Sonali, President of Hingoli Society. Dr. Vidya Rani, the Secretary of Hingoli Society. Dr. Pratima Devi, ma'am, Secretary Imphal. Dr. Mansi Mandale, Treasurer Islampur, and Dr. Sukriti Sharma Jalandhar may not be actually joining us. So now we start. We all have the theory. As you all know, we have cases, and no case comes with a definition that, yes, this is my case. So we have a mix of everything. This is a patient, Priya, who's 25 years old. She comes with severe menstrual cramps and menarche, which are worsening over the years. There's no other significant medical history. So what could be the causes? What could be the causes? I request anyone to take this, please.
The cause could be anything. It can be either primary dysmenorrhea without any reason due to prostaglandins, as our eminent speaker said, or it could be due to endometriosis, adenomyosis, any history of PID, or it could be any other medical problem also, in my opinion. We have to rule out each.
What are your investigations that you're going to do? If you want to differentiate, what are the investigations?
The investigation of choice is ultrasound, of course. In an unmarried girl, transabdominal ultrasound will rule out endometriosis, adenomyosis, and proper history taking and counseling will tell us about PID and any other medical problems. And of course, the history taking will tell about any genetic problem of primary dysmenorrhea.
Yes, Dr. Kazi, sir.
Yes, the same thing I want to emphasize, that this patient may have primary or secondary dysmenorrhea, and first and foremost, we must have to take a detailed history. What are the type? What is the reason? And we have to do ultrasound to differentially diagnose whether there is any pathology which are causing this worsening over the years that you have mentioned, as her menstrual cramps are worsening over the years. So we must have to first differentially diagnose whether this is typically a primary dysmenorrhea or this is secondary dysmenorrhea.
Are there any lifestyle modifications that she can adopt? Because she has had it since menarche. So
Yeah, we must have to know what is the BMI of this particular patient, what are the lifestyles he is right now following, whether there is a stress induced any reason, or whether there is any social stigma, whatever it is. But we have to counsel her regarding her lifestyle modification in the form of dietary changes, in the form of exercise, in the form of psychological support we can provide her.
And also, physical exercise is necessary. That will help.
Definitely.
Aerobics and other exercises, and avoiding junk food, which all these teenagers frequently take.
okay. One thing that I'm interested in is that she had this problem since menarche, but now it's getting worse. So could it be something in her life that has caused it, or it could be some disease that has suddenly changed?
There are chances that is called central nervous system involvement, which day by day, if the primary dysmenorrhea is not going to be treated, there is the reason that pan threshold level decrease, and there are chances of visceral interaction that can cause day by day worsening in even in a primary dysmenorrhea.
Or it could be due to endometriosis also.
Yes. So are there any long-term complications associated with untreated primary dysmenorrhea? You have not treated her. She's on dard hua to ek goli khali shots. So are there any long-term complications?
Yes.
Infertility.
No, she may develop psychological problems. She may develop sleep disturbance. She may develop depression, and that cycle goes on, and that can affect on her day-to-day lifestyle. That can affect on her work outcome, like that.
Sonali ma'am, do you think you want
Ma'am, she made
to prescribe oral contraceptives on her?
Yep. Yes, ma'am. If she her family is completed,
She is 25
I will
years. She's
advise
not
her.
married. She's not married. She's 25.
Otherwise, also I will advise for at least for 3 months. I will advise her combined oral contraceptive pills, ma'am.
Okay. So
Whether if she gets relief, then we can consider it as a primary dysmenorrhea.
okay, so do you think you want to add something that she can do during her menses?
She can add
Now,
NSAID.
Tara ma'am gave you so many things that you can be tried during menstruation, right?
She can apply heat patches.
Heat pads, and also she can take NSAIDs along with.
Yes. So the first case is what we discuss a little in detail. Now, the second case onwards, it's going to be really rapid fire. So this is a 20-year-old and she experiences severe menstrual cramps associated with nausea and vomiting. So what could be the cause of nausea and vomiting during menstrual cramps? What causes?
Release of prostaglandin.
Gastrointestinal symptoms along with lower abdominal pain, ma'am.
Okay, now she also has irregular cycles. So she has pain and she has nausea and vomiting.
Maybe
What
because of intestinal associated with thyroid disorders and or sudden gain in weight or loss in weight.
See, Taru ma'am said that primary dysmenorrhea occurs in ovulatory cycles. Right? That
Yeah.
was the first thing she put up.
Yes, yes. There are the chances of
Even if she has irregular menstrual cycles, her cycles are ovulatory.
yes.
Okay.
Either that is the diagnosis we have, or it is a pain that is not primary dysmenorrhea, it is GIT in origin.
Yeah.
How are you going to
Yeah,
differentiate?
that might be.
So then how
If,
are you, what are you, how are you going to assess this patient?
First of all, ultrasound, detailed history, and then ultrasound.
Okay. So what do
A
you
local
expect to
examination.
find, sir? What do you
GIT
expect to
symptoms.
find? When
There
you
may
do
be
an ultrasound, what do you expect to find?
maybe there are chances of any pathology like endometriosis, or we
Sir,
can say
here she has GI symptoms. Let us see
If GI
how will
symptoms
these GI?
are only for the menstrual only for the menstrual cycle, then it may be related to primary dysmenorrhea. If these symptoms are for throughout the month she is facing, then it is means we have to rule out with gastroscopy or other.
So you brought up an extremely important point, ma'am, that we actually don't, when the patient is before us, certain things don't strike. So that is what we are saying here. She has only during menstruation, she has that nausea and vomiting. So it is primary dysmenorrhea, and we have already discussed.
Or it may be gastritis also due to stress.
But would it strike only during menses, Namita ma'am?
so. If it
Due
is
to
if it is during menses only, then there are most probably chances of because of prostaglandins only. If there is
yeah,
no
that was what I was telling. Due to
because of
P2 and PGF2 alpha, there is nausea and vomiting. Yes.
Ruchi ma'am, would you like to add something to this case?
Yes, ma'am. She is having moderate to severe cramps and happening only and accompanied by nausea and vomiting. So the first diagnosis comes to be primary dysmenorrhea. Now, she is having irregular menstrual cycles that could be related to some other hormonal imbalance also. We shall not try to put everything together and say making a one diagnosis. It could be a hormonal imbalance that is coinciding with her primary dysmenorrhea. So we have to keep this in mind. We should not be clubbing all the symptoms to come to one single diagnosis. It could be multiple factors. For her irregular cycles are a different cause, and her nausea and vomiting menstrual cramps are a different cause.
Yeah. So means, would you advise hormonal investigations?
Are you asking me or the panel? The panel.
I'm asking you right now, ma'am. You've been quiet.
Yes, I
for a
will.
long time.
I will. I certainly will, ma'am. I certainly will.
Okay. You would like to do her hormonal test?
Yes, I would like to do a hormonal test. I would like to do an ultrasound also to find out if there is any other, that is a secondary dysmenorrhea. I will not just based on her history label her as primary dysmenorrhea. I will try to find out the cause of her irregular menstrual cycles.
Okay. So
and we have to rule out PCOD also.
yeah, that's why we asked we'll do hormonal tests.
Yes.
So one more thing is, how are you going to counsel her? Supposing it is just primary dysmenorrhea, then how are you going to counsel her? What will be the content of your counseling?
She is a young girl, we have to remember, and so which is going to have an impact on her health, on her mental status, on her social status, on her work status. So she might be missing her days at work. So first thing is we have to take the scare out of her that this primary dysmenorrhea, and if she's unmarried, I assume, primary dysmenorrhea, it is a common feature amongst young girls, so you needn't be scared. And most of the time it improves after as age progresses, and as you get married, these things are relieved. So of course, she should not be living in pain. So I will definitely tell her that the moment you know your period date is close by and you're going to start your periods, please start taking simple analgesics. Why should you suffer? So, and if she's taking, as I tell my patients, if you're taking analgesics for about say 2 to 3 or 4 days, I mean, what harm does it do? Your month goes very well, you are happy, cheerful, you are going to your workplace. What harm does it do to you? So we should not be living in pain. So that is, I'm going to tell her that please do this, plus exercise, and as sir said, BMI, very important for diet and exercise, no obesity, good food, good exercise, good pelvic exercises which help to relieve the pelvic congestion so that the blood flow is better. So alternative techniques like yoga is a very good exercise. When these children, they do pelvic exercises of yoga, they are reporting a good outcome. So I have to encourage her on that ground.
Okay. So to me, the take-home message is that we should not underplay her symptoms, but we should adequately treat them and take the stress out of her.
Yes, right.
Now, this is another patient. We are to case number 3. She has mild to moderate cramps, which have become more frequent in the past year. She also has a history of depression. Okay. Does the history of depression influence her experience of menstrual pain? Uma ma'am, aap bolenge kuch? Ma'am, you are muted.
Hello.
Yes.
Good morning. Good evening, ma'am.
Good evening. Ji ma'am. Ma'am, pre-existing depression से menstrual pain.
Severe menstrual pain may lead to her in a depression in her life because she might miss her work and classes and all. She might be isolated in her social surroundings, and she might be very much feel low very much. So we have to counsel her that she can improve with the alternative medicines like yoga, diet and all, and with medicines, as madam has said, the NSAIDs before she can take before the menses. So
Ma'am, she is already a case of depression. She's already a case of depression. Okay. She is under treatment for depression. So the question is, does the depression worsen her pain? That is the question.
Yes, ma'am. When she is depressed, more prostaglandins might cause severe pain, dysmenorrhea to her.
Deepshika ma'am, would you like to add something?
A very tender, loving care might help her to come out from her depression, and proper medicine, proper care and proper treatment might help her to cope up the situation.
Okay.
Ma'am, we have Dr. Helen and Dr. Vishang also. We can ask them for their inputs too.
Okay. Dr. Vishang, would you like to add something here? Dr. Vishang?
Dr. Helen, ma'am, would you like to add something?
Yeah, definitely. Because when Madam Taru Madam had also, when she was giving her presentations, and I think this is a recurrent theme. Pain, any type of pain, we are discussing dysmenorrhea here, any type of pain definitely carries some psychological affliction if it is long term. So in this particular case, she already has a depression, and dysmenorrhea might be adding to it, or the chances are that it might aggravate her already pre-existing psychological intervention. So she needs psychological counseling. She definitely needs psychological counseling. At the same time, we should be treating her dysmenorrhea as per the guidelines. We can start with NSAIDs first, and because every guidelines are there just to help us out. So we can keep tailoring our management depending on her response to the treatment that we have given. Psychological counseling definitely will have a lot of impact if we can, if the patient receives it. In her case, I feel.
Are you going to send her to a psychiatrist, or you are going to do it yourself?
Ma'am, in this particular case, since she already has clinical depression, so I think a professional would be better. From my perspective, I would definitely counsel her on why dysmenorrhea occur. Patient's intake on my advice might not be that good, but when combined with the professional counseling, I think it will help a long way.
One thing I want to ask everyone, all the faculty present here, many patients say that we have heard if you take analgesic in these menstrual pains, then it causes long-term harm. It affects the fertility. They have a lot of doubts. So what can you do to elevate these queries? They have these doubts, these myths in their head that, the painkiller will not let them conceive in the future. It harms the body. So how do you counsel in this situation?
With certain conditions, with certain people, it tends to improve with time also. So if the intake of NSAIDs might be required for some time and we can see the progress, depending on that, if there is no symptomatic improvement, we can even use hormonal treatment, and that might bring some improvement. So we can counsel that instead of letting the pain allow, of course, we have to consider two aspects first. Number one, patient's understanding of her disease. If it is there, then it becomes easier for us to tell her how to follow up also. So if she can understand what we are explaining about dysmenorrhea, then it becomes very easy. Then it is easier for us to also explain that pain management is important because it affects quality of life. And if quality of life is affected, long-term psychological impact, that is going to have a negative impact. We have all heard about the good cycle of how endorphin works on our health, mental health, physical health. So that way we can explain that if the pain can be alleviated, it might have a positive impact. And regarding her concerns of long-term use of medicines, of course, everything has its side effects. If we feel that after certain point of observation she is not improving, we always have alternative therapy that we can consider. And additional adjuvants we were discussing, non-hormonal treatment, non-pharmacological pain management techniques. These are all things that can be used along with medicines if she has deeper issues with long-term intake. So I think we can counsel her that way.
Okay, so
I just want to add something, ma'am,
yes,
with your due permission.
yes, sir, yes.
So what we have seen in a patient of this type of depression, there are chances of sensitization of central nervous system. So already the pain of primary dysmenorrhea, which can be exaggerated in this type of patient. So definitely, there is some problem. So definitely, according to the ma'am says, we must have to counsel her at per our knowledge. But my opinion is we should advise her to take counseling by a psychologist also in this particular case.
Thank you, sir. So next we go to the next case. Now she's 22 years old. She has severe cramps on the first day and she has diarrhea and fatigue during her periods. So what are the reason for Deepika's GI symptoms?
Again, role of prostaglandin.
No, that is the theory, but what are you going to differentiate? How are you going to differentiate?
By taking by proper history about the pain and dysmenorrhea.
Would you ask about any specific diet? Whether any diet is triggering it or whether some diet that she takes makes the pain get better? Would that be part of your history taking?
Definitely, ma'am.
But the diarrhea is on first day of her period only, not the whole month.
Yes.
So if it is by diet, then it should be a whole month or in between off and on.
Now, supposing, let us take it further. Supposing it is in between off and on, then how would you, differentiate? How would you differentiate? For GIT, what are you going to investigate?
So we can do some allergy tests. It could be allergy to lactose intolerance, or it could be nowadays wheat allergy is also very common, celiac disease.
Okay, that is correct. Dr. Sonali?
Yes,
Would you add
ma'am.
something?
Yes, we have to rule out other inflammatory bowel disorder.
Okay, so that
Can
we
I add
have.
something, Dr. Asha?
Yes.
Irritable bowel syndrome is a very common finding in patients with dysmenorrhea.
Yes.
Definitely.
Yes. So what are you going to do about it? The patient is in front of you. She's come with dysmenorrhea. So what are you going to advise her?
Antispasmodic drugs.
If she has concurrent IBS, and we know that with every stress, IBS gets worse. So this menstrual pain is a stress and is continuous.
Therapy.
Yes, ma'am?
Non-pharmacologic therapy, we will advise her, ma'am.
So what dietary change are you going to advise?
If she is not lactose intolerance, then increase in dairy products, we can advise to have ginger to
Dahi, chawal, fruits.
yes, means all these which have reported in study, we can advise her.
Okay. Anybody has anything else to say? Would you go with more of
spicy.
vegetables and fruits, stay away from spices?
Vegetable and fruits, avoid the spicy food, and oily food she should avoid. And she should take the very light diet like chawal, dahi, etc., kela, and all.
Easy digestible food.
Okay.
Easily digestible.
So
low fat.
Now she has
Vegetarian
followed your
diet she
advice
can have.
and her GI symptoms are better. But how is she going to manage her fatigue? She feels very tired, as though there's absolutely no energy. How will she manage her fatigue during dysmenorrhea?
She
She
can
can take all along with other supplements.
Vitamin B1
Vitamins,
supplementation, vitamin E supplementation.
Yeah, 200 to 400 milligram per day. Vitamin E has a good role.
Do you think we should at least do a CBC? Means
Yeah.
anemia
Yes.
is 60% in our country.
Rule out the infection, GI infection.
Not just infection, ma'am. She might just
Anemia.
be a low
Anemia.
hemoglobin.
Yes, yes.
As,
Yes,
as her history
definitely.
suggests that there is a
Definitely
more
we have
first day
to
of
do.
menses, so there are the chances of she may have more bleeding on that day, and
So we need to do a CBC at least.
Yes.
And in your practice, how often are you doing vitamin D, B12 levels?
If the
Not
patient is
routinely.
complaining of fatigue or some problem, then we are doing, not
Not
regular.
routinely we do, ma'am.
Routinely
But
not
she
doing.
has complained of severe fatigue. So
But routinely we are doing hemoglobin, blood sugar, thyroid, TSH. This we are doing regularly in adolescents. Yes.
okay, and vitamin D.
Vitamin D not regularly if the patient is complaining of some backache.
This patient, would you want to do vitamin D?
Yeah, we can do.
Yes.
To do.
Ruchi ma'am?
Yes, ma'am. I would like to do B12 as well as vitamin D for this patient.
Yes. So we need to find out whether there is something else going wrong with her as well. Now this patient she's 18 years old. She has mild to moderate pain, but her concern is, एग्जाम टाइम में पेन होगा तो मैं क्या करूंगी? What will I do if I get pain during exams? So do you think dysmenorrhea can affect concentration and academic performance?
Definitely.
Yes, definitely.
Yes, definitely.
Yeah, definitely it affects.
It has been seen that psychological factors in patients who are already having a high anxiety score and a high depression score, they do badly.
Even
I
the
mean, it's
girls
vice
who are
versa.
school
With
going,
dysmenorrhea and then the dysmenorrhea further affects it. So it's like a vicious cycle.
even the girls who are going, who are school going, they have under stress. So it also, this is the cycle, stress and pain, pain and stress.
So what can she do to, reduce her stress during exams? Now, these 1 month of exams, and she's going to have her periods in between. So what can she do to manage her symptoms to feel better during exams?
I will advise her NSAIDs or hormonal.
Here, see,
1 to 2 days before her periods. Yes.
Yes.
She will start NSAIDs 1 to 2 days before her expected periods so that it may act when it comes.
Okay. So
Can we
Proper
give,
counseling, proper
ma'am, can we give
psychological
oral
counseling.
contraceptives in this cycle just to make it anovulatory?
उतने दिन पहले नहीं आई ना मैम आपके पास? She has to come at least 1 month before you can ask her to have OC pills. Now she has come, I have my exams starting next week and I have this problem, what to do? Are
Oh,
you
this is typically related to stress. So proper counseling is must. This is just not because of the dysmenorrhea.
Yes, that is a very, very, very important point, that it's not just dysmenorrhea. The stress is multiplying it here.
Yes.
So we need to counsel that you need to relax, offer her as placebo some dietary changes, some exercise, and everything will act together.
Yeah.
Do you think premenstrual syndrome has anything to do with her stress, academic stress?
Yes,
Okay.
there are chances.
So then, how will she manage her academic commitment with, self-care during medication, during menstruation? You're asking her to do some walking, some exercise, and she is studying and sitting in one place all the time. So how are
Yoga.
you going to counsel her about balancing it?
I will advise her to do at least 15 minutes to 30 minutes of yoga regularly. That will definitely improve her concentration also. And it also decrease her stress and simultaneously the pain also.
Meditation is good for her.
Dr.
Anaerobic
Manish had
rest
said
for
that you should do a sonography,
minutes.
just to say that everything is fine. So I think
Yes.
I go with that here, that you
Yes.
also rule out other things and you also relieve the stress involved, that there is nothing really wrong. So now we go to the next case. This is 28 years old. She has severe cramps which have worsened after giving birth to her first child. She is breastfeeding. So does childbirth and breastfeeding influence her experience of dysmenorrhea? Ruchi ma'am? Helen?
As we know that in married people with progressive deliveries, there are chances of adenomyosis increase, and these patients, these kind of patients, they will experience progressive dysmenorrhea as the time goes by. But this is her first child, just she's breastfeeding. I think I just have to counsel her that if you keep on breastfeeding, that is a good for you in the long run, for the baby as well as for your health in the long run. And will because of good breastfeeding, your ovulation might be delayed, and if your ovulation is delayed, then you might your dysmenorrhea will get better.
Okay. So, we all know when she's breastfeeding, there are high levels of prolactin.
Prolactin, yes.
So, does that have anything to do with her dysmenorrhea? High prolactin levels? Could there be any condition that is in her, during childbirth, something happened that made her have more of dysmenorrhea? Is something like that possible?
Sometimes there is a psychological stress of delivery.
Yes.
She might have
So-
developed PID, pelvic inflammatory disease.
No.
A patient with primary dysmenorrhea, once she undergone with a painful process of delivery, that can also aggravate her symptoms, or there are chances of some postpartum or psychological disturbances that can cause this thing.
Okay. Okay. So, what are you going to offer her? You've examined her, you haven't found anything wrong with her. So, what are you going to offer her now?
As ma'am suggests that let her to continue breastfeeding, counsel her properly, give her psychological support, that by time and with some bit.
Do you think you're going to give her hormonal
Progesterone
only support?
Can give her.
Yeah, there are the chances
POPs
that
can be given.
Yeah. So, you would like to try that for 3 to 6 cycles, right?
yes, progesterone only pills we can offer her.
Progesterone only pills would help. So, now we come to another patient. This is a really tough one. She's 40 years old. She's always had mild to moderate cramps with heavy menstrual bleeding. Now she's tired of it. I mean, she's always had it, but now she's 40, her family is complete, and she doesn't want to, go through it over and over again. So, do you think because her tolerance for that pain is gone, she's feeling it more?
There
Maybe
are
can
possible.
Sorry.
Yes, you
Sir, please continue. Sir, please continue.
So there are the chances that continuous pain since last maybe 20 years, if according to her history.
25 years at least.
At least 20 to 25 years. So there are the chances her level of threshold has gone. So at this age of time, we must have to examine her properly. If there is no any other thing, any pathology, her cervix is normal, no PID, no abnormality in ultrasound, we can offer her long-term contraceptives like LNG at this stage of time.
Yes, sir. And
her tolerance probably has gone.
Yes,
Dr. Asha, her tolerance probably has gone. She is bleeding heavily and she is might be anemic.
Yeah.
She bleeds every month.
Yes. And now that she has come to me, I would like to take the opportunity. There are many gynec oncologists here to also do her HPV test and pap smear. She's here, so let us do that. That is part of the investigations. And then we'll do her hemoglobin and ultrasound, a transvaginal scan to find out what is wrong. And you find nothing much. When a patient says that I have heavy menstrual bleeding, and you find that her hemoglobin is 12.5, what do you say to that?
We will take proper menstrual history, because according to patient, heavy menstrual bleeding is a different thing. According to criteria, heavy menstrual bleeding is a different thing. So we have to tell her to maintain menstrual diary, and we have to check. whether what she is telling heavy menstrual bleeding is the same or not.
Okay. So now LNG IUS is what everybody has agreed on.
Yeah, agree.
Okay. So would you also like to do anything else for her perimenopausal status, or that's enough?
We have to give calcium also.
Yes, ma'am?
Calcium.
You have to give calcium. You have to advise lifestyle changes, yoga, exercise, postural correction.
Yes, ma'am.
Correct her vitamin D levels. Get her proper shoes to walk in. You know, all that, because pain felt may not be actually pain in that organ. It may originate from the spine.
Yes, ma'am.
So now she has not agreed to anything that all 14 of us have said. She says, I want a hysterectomy. Would you go ahead and do a hysterectomy on her?
Still we will counsel, ma'am. Still we will counsel. As you have said, pap smear, HPV testing, ultrasonography, local examination, everything is normal. And even though she is telling that she wants to remove her uterus, still we will take chance with our counseling that we could make her understood that this is not the reason to remove the uterus, but at this stage of time, if she insists on again and again, even after the proper counseling and everything, we can go for it.
Helen, would you
But
like
it
to?
is not justifiable.
Yes. Yes, sir. Yes, Helen.
Sir, I beg to differ out here because this is a patient who's 40 years old, has completed her family. We have investigated her, did not find any other cause except for her, except for confirming that she's having this condition due to constant pain. So if we can improve her quality of life, it's a consideration that we can give. If with medical, what I would do, usually what I do in my practice, patient comes like this. And like sir said, counseling done. So I give her at least like a month or two to see whatever medical treatment and sales or OCPs I give, if that is improving. If she feels good, then I tell her that if she feels good, we can continue with it. If not, then definitely we'll take the first step that you want, hysterectomy. However, in doing so, I explain at the same time that sometimes there is a collateral damage in the sense that if you remove the uterus, then she won't have menses. So that aspect of castration psychology should also be explained prior. So there are like two aspects to everything. I would definitely consider, but then at the same breath, I think I'll tell her about the problems with doing hysterectomy also. So it's not like
Definitely, ma'am. We have
nowadays,
Definitely,
yes, sir. Yes, sir. Sorry, please go ahead.
No, please, ma'am. Please, you continue first.
No, sir. I think how you say it.
No. Please, ma'am.
Okay. So, sir, for me, how I do my counseling nowadays, I mean, when I was evolving as a young doctor, that time it always used to be, okay, the book says this, there's the book says that, and that's how the counseling started. But now it's more of a, partnership with the patient regarding what are the things that she can expect out of it. And if she's okay with it, like we get a lot of.
Had this discussion, Ruchi, Helen. Now I go to Dr. Ruchi, ma'am. So,
Yes,
ma'am, you are the jury. What would you say? You will do a hysterectomy or you'll not do it?
No, ma'am. Thing is, that most patients are unaware of the menopausal changes that happen. They are absolutely unaware. So I will tell her, see, the natural age of menopause in our country is 46, 47. So if you are going for a hysterectomy at 40 years, what would happen at 7 years later is going to happen now. And most of the time they don't know about it. So when you counsel them, then they ask you, ki kya ho sakta hai? And then you tell them, see, this is what is happening. Your heart, your bones, your whole system, your weight, everything will go haywire. So why don't you take my advice and try the medication that I am giving you, whether it is an LNG or whether it is an oral pill. Try taking that, see whether you improve or not. And believe me, when you counsel them and actually show them, impress them that the menopausal changes will be really drastic, then most of the times they grasp they're ready to take that counseling from you.
They think that the work
In
of uterus is over, so they should get rid of that. They're
In my
thinking
experience, I have seen that a woman who has pain before also has pain after. Because we have not been able to manage the cause of the pain. She had pain before, she was tired of the pain. Now she has had a hysterectomy. 6 months into the surgery, she'll still have that, wahan pe pain hai, tenderness hai, that goes on. So mostly I feel we should all participate in that counseling and treating that pain psych before we actually plan on putting the knife in any form.
One thing I want to add, ma'am.
Yes, sir.
We are talking about counseling. That is not a counseling only. That is a counseling with confidence. If we will show the confidence that yes, I am confident enough, you just follow my advice, and definitely upon a period of time, you will get be benefited with this treatment, and you might not need any other surgical intervention.
yes, sir. Okay.
So now we come to case number 7 or 9, whatever. This is a patient who previously had PID. That PID got treated. She doesn't have any symptoms. Now she has come with menstrual cramps. So does a history of PID contribute to dysmenorrhea? And what could be the cause?
There might be adhesions formation due to PID, so that will lead to secondary dysmenorrhea.
Okay, that is one thing. So how are you going to assess that? Whether it's due to adhesions or something else?
So again, the ultrasound is the gold standard. It will show tubo-ovarian masses.
No, she doesn't have active PID anymore. She doesn't have active PID. She just has the pain. So how are you going to assess that? Uma ma'am, Dr. Vishang?
If she is having pain even after taking the antibiotic treatment properly, then we might have transvaginal examination. Sometimes hysteroscopy might be helpful to exclude the adhesions in the uterus, and diagnostic laparoscopy to diagnose any adhesions in the lower abdomen or endometriosis and all.
Okay.
In cases of PID, ma'am, there are chances of chronic inflammation. So these all inflammatory factors, apart from prostaglandin like interleukins and VEGF, there are chances because of that also she may have continuous menstrual cramps.
Okay. So how are you going to relieve that? What are you going to do to relieve that pain? You're going to give her anti-inflammatory agents or you're going to give her antibiotics. Do you think antibiotics have a role here?
Yes, definitely. We will take a proper history. What type of antibiotics she has been taken since last few months, or maybe whenever she was having a PID, whether she took a proper antibiotic course or not, broad spectrum antibiotics she had taken or not. If not, we will complete the course, and along with anti-inflammatory agents, we can give her.
Sir, you did her CBC, which was normal. You did her C-reactive protein, which was only 3. So she doesn't have any active infection at the current moment. Would you want to give her a course of antibiotics then?
If she's not having any vaginal discharge, then antibiotics won't help, I don't think. We can give probiotics although and vaginal washes. And high vaginal swab can be sent for culture sensitivity.
Okay. Anybody thinking of UTI?
Concomitant visceral
Yeah.
connection can be there. So we have to dipstick urine and urine culture we have to do. There are chances.
Okay. So we also want to think of the bladder. We've thought of the rectum and the bowel. Now we also think of the bladder a bit when the woman has come with that problem. A past history of PID doesn't mean she has it now, but we need to exclude. And Uma ma'am was right that we are going to do a laparoscopy if there are adhesions which can be confirmed on a transvaginal ultrasound, and our PV examination where your mobility and all is affected. You can see adhesions on ultrasound, then we might go ahead and do that. So now this is a 27-year-old. She has cramps during, it's not just day 1 or day 2, but for about a week, she has those cramps during her periods in the first week. She is trying to conceive. Now she feels that her pain is getting worse. What could be the cause? She says, I'm getting this dysmenorrhea since I've started trying to conceive.
Pelvic.
Ruchi ma'am?
Yes. Ma'am, she's a 27-year-old who's trying to conceive, which means she's into regular intercourse with her partner. And she might be having some pelvic infection or even a urinary bladder infection, repeated UTIs, and that could be the cause of her pain. I think in this patient, I particularly would like to rule out any vaginal and a pelvic infection and a urine profile before, to make things easier for her.
Ma'am, this I think is a regular OPD occurrence with us. People have been married 4 years. They are together. Now, when they are trying to conceive, they are so invested that this time I want to get pregnant.
Yeah, the
and they
stress,
get
the obsessions. Yes. And it's also probably sometimes, ma'am, when they are having infrequent intercourse, like when the husband is out and he's coming for one after a month or after 1.5 months, posted here and there. Infrequent intercourse leads to these kind of problems. Too frequent intercourse can give her the infections. And third thing is, as you said, the stress. Previously, they were not trying, and now when they see right and left their peers getting pregnant, they start getting this apprehension that why am I not getting pregnant? I've been trying, so everything adds on to it.
Yeah. So do you think, she's had an ovulation induction? After that ovulation induction, she made a really good egg. There was timed intercourse. She was given progesterone. And then she had her periods. So do these medicines have an effect on her dysmenorrhea? The ovulatory and the progesterone, does it have an effect on her dysmenorrhea?
No, in fact, if we are giving progesterone, that can decrease the chances of and severity of the dysmenorrhea.
Due to progesterone withdrawal, there is dysmenorrhea, yes. That's why in anovulatory cycle, there is no dysmenorrhea. The action of OC pills is also that it inhibits endometrial proliferation, and that's why it protects against dysmenorrhea.
So because she has progesterone and that progesterone withdrawal has happened. So I think counseling her about that, everything is good.
Yes.
You might conceive next cycle. That should work.
Yes, yes.
There are also chances that the same pain which she was feeling before trying to conceive, psychologically it will increase if she will not conceive. That stress also influence that pain sensitivity to increase.
Yes.
So the same thing, proper counseling and to give her confidence with this oral ovulations and this treatment, definitely if she is having not that much another problem, tubal factor or anything else or husband factor, we must have to give her confidence that within 2, 3 or 4 months she will get conceived. That confidence will boost up her moral and decrease her stress. So there are possibility that she will not feel that much pain. And if she is confident enough and stress free, believe me, there are chances of good result with the treatment of infertility.
Thank you, sir. So, sir, this case I have put up that for just one reason, that there is a girl, she has a family history of endometriosis. Her mother had it, one of her sisters had it. She has not been diagnosed, but she has that worry that, maybe I also have endometriosis. She gets severe cramps during menses. So, if there is a positive family history, does it increase her chances of having endometriosis?
Some of the literature suggests that there are chances of family history of dysmenorrhea. So yes, there are chances of increased chances of dysmenorrhea in this particular girl.
Okay. And what are the investigations you would want to do to set her mind at rest?
First of all, we will do ultrasonography. Not for diagnosis. Believe me, ultrasonography right now is not a diagnostic tool for a gynecologist. It is a routine OPD checkup for each and every patient. You put a probe, even in an unmarried girl, you put a transabdominal probe, and with smiling face, if you are telling that, look, girl, you are not having any abnormal pathology. I have done your scan. Your uterus and your ovaries are absolutely fine. Her 50% pain will go down in next cycle.
So, sir, one thing I want to ask everyone, that she has a family history of endometriosis, but can her pain be due to something else, or it has to be endometriosis only?
First of all, we have to proper history of this particular girl, keeping apart her family history. If we are not finding anything else, we can relate this thing to her family history.
Okay. So now we come to the last case, and this is a 23-year-old girl. She has mild menstrual cramps, but her concern is irregular periods. So she wants to know whether it is because of irregular menstrual periods she's getting pain. Dr. Sonali?
I will tell her it's not because of the irregularity that she is having dysmenorrhea.
Okay. So how will you assess her? What tests are you going to do?
Irregularity may be because of, means I will ask her whether she has, whether there is any weight gain or any lifestyle changes are there.
If there is
And
any
also,
hirsutism.
yes, on physical examination, whether she is having any other symptoms of hirsutism, signs of hirsutism, and PCOD. Other hormonal pathology also I want to rule out relating to thyroid.
Her concern is not the pain. Her concern is her irregularity, because she doesn't know when she's going to have her period. So what would be, in your view, the first thing you want to give her? You're going to investigate her, but what are you going to do with her?
OCs. I would like to give her OCPs because that will regulate her cycle and it will also help her with the dysmenorrhea.
Yes, madam.
So for her, the first choice would be Ocipils, and you want to investigate her for PCOS, you want to investigate her for hypothyroid, right?
All the hormones, yes.
So what are her long-term management options? She's only 23. Today, girls don't get married at 23. So she's going to be married maybe when she's 25, 26. How long can you give her Ocipils?
For 3 months. And again, wait for
only 3 months?
at least,
No, we can give
for
her
3 months.
longer period of time. There is no problem. Low dose Ocipils for longer period of time with proper counseling we can give. If she is not having any other hormonal problem like PCOD or hypothyroidism or hyperprolactinemia, if she is normal with all other hormonal things, we can give her low-dose for at least 6 to 12 months. No problem with low-dose.
Well done.
Okay. So now we are at the end of our panel. And before I actually end it, I would once again request for your help. And then I would like everyone present here to give take-home messages, and we are right on time. So one message from this panel, what you want to say to your audience. Sonali ma'am, I'm asking because I see you at the top of my screen.
Primary dysmenorrhea is a normal phenomenon. So we should counsel her, and lifestyle changes I will offer to the patient.
Okay. Helen, one take-home message from the panel today.
Should I or?
Yeah. You say it, then Ruchi ma'am, then we
Ma'am,
go
can
to
I
Dr.
take a little
Subodha.
bit more time? Because
Okay. Dr. Subodha, sir, one take-home message, sir, from you. You are muted.
Yes,
Yeah.
one word of caution from me about for everyone about using these NSAIDs, because indiscriminate use of NSAIDs may not be from the doctor's part, but once we start prescribing this, some of the girls, even in a very young age, they start taking this NSAIDs a little indiscriminately, and they become addicted to it. Some of them I have come across patients, and even as we have discussed, long-term this dysmenorrhea, it will lead to depression, and even without pain for depression also, some of them just take this NSAIDs thinking that it's going to relieve their symptoms. And I have personally come across a girl who ultimately ended in renal failure. So we should counsel and make sure that they never take it more than what is required. And that is something we have to be very cautious about, and we have to counsel our patients well. Of course, the importance of this counseling in all these patients that cannot be overemphasized, as I have already said. Thank you. Thank you all.
Thank you, sir. Kaji, sir,
Yes, ma'am.
one take-home from you, sir.
One take-home message from my
And then,
side.
sir, I'm coming to you, Gurnesh, sir.
Give your proper time for the counseling to the patient of this primary dysmenorrhea, and time and counseling is the medication for this type of patient. Apart from giving symptomatic relief or hormonal therapy, give your time and your smiling face, confident counseling is must for this type of patient. This is my take on this.
Thank you, sir. Gurnesh, sir. फिर दीपशिखा मैम आपके पास आऊंगी.
What I have found, even as a HOD and even as a professor, is to sit with the patient, talk to her, and don't think that in single sitting you will treat the whole patient. Do the follow-up. I have found within 3 to 4 months, most of my patient improved more than 90%. I could advise on lifestyle changes also. I could advise on sleep habits also. I could advise on NSAIDs side effects also, COC pills follow-up also, the problem with COC pills also. But I could never say that within one sitting only I could do. In one sitting only 20 to 30% people will only improve. But only when you go for 3 to 6 months, then most of them improve.
Thank you, sir. Thank you, sir. So Kazi, sir, and you, both of you are basically more invested in giving your time to the patient multiple times. Thank you, sir. Dr. Deepika, you're ready, Helen?
Yeah, ma'am, I was arranging something. Yeah, so like I think recurring theme was counseling. And definitely it applies for all disease and all the more effective for dysmenorrhea also. When majority of the time we find patients' acceptance to our advice easier if we have counseled them properly. So proper counseling, and counseling not only regarding disease, because lifestyle influences have been noted to affect these particular conditions. So we counsel not only on the disease, we counsel about lifestyle. If there are some negative impacts, we have to tell them these are the aspects that you need to change. And like Kazi sir and Gurnish sir said, you cannot make out in one sitting. You have to have multiple sittings to understand what perspective of lifestyle modification they need to do. And sometimes tailoring patients' requirement becomes easier if we take out time to get to know them. So that would be my message too. Thank you. Can I move on, ma'am? I have
Yes, yes. Thanks a
Thank you
lot.
so much, ma'am. Thank you. Thank you all. So nice to have all of you meet like that. Thank you so much. All the best, ma'am.
Thank you. Thank you.
Can I come in, Dr. Asha?
Yes, Ruchi ma'am. Please go ahead.
First thing is never underestimate, never underscore the patients who are coming with a complaint of pain. Patient is always right. Second point is, as for these adolescents, they are suffering from this dysmenorrhea and PCOS. If we can counsel for PCOS, we can also counsel for dysmenorrhea. And third point is, as Subodha sir said, when I write NSAIDs, I always write only during periods. I write it in my prescription in brackets because Hare Patte Wali Goli is a very, very popular dawai with people. So I write there only during periods, so which is max 3 to 4 days. So I ensure that they are not taking beyond it and indiscriminate use. Thank you very much.
Thank you so much, ma'am. Kind of you to be here with us whole evening.
Always a pleasure, ma'am.
Dr. Deepshikha?
जी मैम। मैम काउंसलिंग अपने आप में बहुत बड़ा रोल प्ले करता है, बट हापुड़ जैसे थोड़ा छोटा शहर है, रूरल एरिया बहुत ड्रेन करता है, तो पेशेंट की काउंसलिंग, लड़कियां ज्यादातर अकेले नहीं आती विद द कंप्लेंट्स ऑफ पेन, दे कम विद आवर मदर और पेरेंट्स. तो काउंसलिंग ऑफ द पेरेंट्स इज ऑल्सो वेरी नेसेसरी बिकॉज इट इज कंसिडर्ड एज taboo and inadequately treated in majority of cases. So counseling of patient and with parents, it is very necessary.
Thank you, ma'am. Thank you. Uma ma'am, आप हैं? Dr. Uma? Sujaya, over to you before
Yes,
I
ma'am.
end it.
Yeah, last but not the least, what everyone endorsed was empathy towards patient, proper history taking, so that you can come to a conclusive diagnosis and give them moral support, as in adequate amount of counseling would go a long way in treating their dysmenorrhea. I think that should sum it up.
And I would like to put my little bit that we need to actually, what Ruchi ma'am said, the patient is right. Don't underestimate her symptoms and give her adequate pain relief. Whether it is hormonal, whether it is NSAID, whether it is counseling, but you have to treat her pain, irrespective of what you feel about it. So I think that is the biggest message, that the pain is real. We look for the cause and then we try to treat it. So thank you. Thank you so much, everyone, for being here. All my experts, the chairpersons, panelists, everybody is still here. So thank you very much. I hope we have all learned something today. And thank you, Corona Remedies. We meet again next week and we will be discussing an obstetric topic, that is mid-trimester anomaly, and how you're going to deal with a report of only soft markers positive. So only soft markers positive, and what are you going to do with that is what we are going to discuss next week. See you again. If you want notifications of this webinar, which happens every week, Wednesday, 5 o'clock, please subscribe to the channel. Thank you. Thank you once again. Thank you.
You were always as great as usual, Dr. Asha. It is such a pleasure to be in your Searchlight meetings. Believe me.
Thank you, ma'am. Thank you.
Thank you, ma'am.